What I want to do today, I have more slides here. For those of you who picked it up, please don't think I'm going to go through every slide. I think I have about 45 minutes, and even 45 minutes, I can't get through everything, but I thought that at least people could have some of this. I thought there would be a lot of community practitioners, although I don't know how many are here in the audience. What I want to do is try to cover as much as I can to make sure at least all the panelists are on the same page. I can't believe that most of you have not been following the issue with avian influenza over the last few years, so I'm sure you know a lot of what I'm going to say, but I hope that, that in the course of the presentation you'll hear some things that perhaps you haven't heard and will come up in discussion. You can stop and interrupt me anytime, although I may tell you to hold that for a little bit later on. And some of these slides I'm not going to go through each piece in the slide. It's sort of the slides there from, this is kind of a conglomeration of talks, and I've pulled things together trying to sort of emphasize points. And what I want to emphasize on the points on this slide is the difference between seasonal and pandemic influenza. I think a lot of people assume that pandemic influenza is going to occur between October and March or April of any given year, because that's when we usually experience regular seasonal flu. In fact, that's not the case. A pandemic influenza can occur in any time of the year. It's when basically the organism, whatever the novel strain is, becomes easily transmissible between susceptible people, and that's when you can potentially have a strain. And of course, for regular influenza, the source is usually humans, not chickens or birds or some other animal, whereas with the pandemic flu, it can be other people, but usually animals are the principal source. This is, and I think this is telling. I mean, clearly Katrina and Wilma and the tsunami and the natural disasters that we've had have really opened our eyes to, how we respond or how we can't respond if we're not organized properly to a catastrophic event. And frankly, this is meant to illustrate that if we have a pandemic flu, not just H5N1, but any strain, clearly it will dwarf the experience that Katrina and Rita and Wilma that we had with those particular hurricanes. The talk that I'm giving today, I should add also, is not just specifically focused on H5N1. I will talk about avian flu, but really our preparedness efforts are geared towards any pandemic strain, not just H5N1, although that's the one that we're most concerned about right now. A principal point I want to make, you probably all know there are A and B strains. There's also a C strain that basically doesn't cause disease in humans. And the influenza variant, actually the initial slide had some pictures of it, has an envelope, and there's some proteins on the envelope that, without getting into the details of what these various proteins do, it's suffice it to say that what they do is to facilitate replication and transmission of the virus between cells in a human. And some of the antiviral agents are basically geared against these surface proteins. When we talk about pandemic flu, you know that the regular influenza vaccine has three basic strains in it, two A's and a B. There's only one B. There's basically only one B strain, although it can vary a little bit from year to year. But it's really the A strain that causes influenza pandemic, not the B strain. And clearly, the various A strains can infect all kinds of mammals and wildlife, and you've probably heard about that, and we'll come back to it. Wild birds are a natural registrar. We have HA and NA as being the subtypes. There are 15 subtypes, I think, of HA and 9 of NA, and clearly when you combine them, you can get lots of different combinations of subtypes. And I don't really want to talk much about B and C today, because C really doesn't wind up being a significant factor in influenza. Most of you are health professionals, I presume, and you've learned about influenza, and you know about the concepts of shift and drift. Shift is what happens essentially when we have a novel strain, and basically you've got a complete change of the virus itself, such to the extent that humans are basically naive to the virus and are susceptible to its infection. Generally, it occurs with the reassortment of the gene segments, as opposed to drift, which is what we experience year to year with influenza, where there's some changes in the amino acids and there's a different configuration And it's the reason why we have to have a new vaccine every year, which is unfortunate in some ways because it means you've experienced all the problems we've had with having a new vaccine every year, namely shortages or not being able to predict far enough in advance what the strains are going to be, and then finding out that the circulating virus that's causing disease in the community doesn't quite match with the vaccine you prepared, which is something we had a few years ago, and then, of course, the vaccine isn't as effective as you would hope it would be. Again, re-emphasizing that when we're talking about pandemic, we're talking about a shift in the influenza A virus. Seasonal influenza, I mean, you know what kind of disease it causes. What I want to emphasize here is the fact that incubation period is relatively short, just in contrast to SARS virus, the incubation period was about 10 days. And also a distinction between those two viruses is that an individual can be shedding viruses for actually, particularly children, several days before they become clinically ill, which is important because they're asymptomatic, shedding virus, infecting other people, and it's a very difficult disease to control because it's got asymptomatic spread and it's got a short incubation period, and it can be in the community very quickly. SARS was different, as I say, 10-day incubation period, and people weren't infectious to others until they got sick. So there was a lot easier to control the disease through contact tracing as opposed to basically seasonal influenza, and obviously as it applies to pandemic influenza as well. Just to give you some idea of, you've heard this, this figure about 36,000 deaths annually expected from influenza. You notice how it's exactly 36,000 deaths, not one more, not one less. Amazing, isn't it? Well, clearly that reflects the fact that it's based on modeling and estimates from, there actually really isn't good surveillance for, when I say good surveillance, it's not really good, where you identify influenza infection in people. So it's based on estimates on pneumonia and influenza, on hospitalized cases, and it's, but there it is. And obviously deaths are tip of the iceberg, which is what this slide represents. And there's much more morbidity than there is death in the population, and all of you have had flu, so you know how significant it can be even among healthy people. This slide is, I just put this in there to emphasize the fact that I mentioned a moment ago about children. Children, frankly, are basically how influenza is spread in the community. Children can be shedding virus infectious for several days before they get sick. And then, of course, they're sick. They may not be terribly sick, depending on their age, and they go to daycare or preschool, and they basically affect other children. Those other children go home, infect their siblings, and then their family members, and so on. And in fact, as a result of this and other work that's been done over the years, we're close to, although I can't say it's done yet, but very close to proposing regulations that are going to require that all children attending daycare, licensed daycare, and preschool will require influenza vaccination in the state. We would be the first state to do that. It hasn't cleared the process yet, but we're hoping to move forward with proposing those regulations, which would be a very good thing, not just for controlling annual influenza, but I think ultimately in some ways pandemic influenza as well. This slide, again, we're not going to go over some of this. You can read it on your own. It just talks about the various complications that can occur with influenza. The bottom line is you can be not sick at all to die, and anything in between in terms of complications versus respiratory complications or CNS complications and others are clearly possible. Testing for influenza is an important issue to deal with, particularly in a pandemic. Most of the time testing is not done. People come in. I mean, very often, the adage we teach medical students: if you're not going to do anything different with the test results, then don't test. And so, if a patient comes in with 3 days of symptoms, what are you going to test for? Unless you think it's some other disease that you want to rule out that's treatable, you might not really need to do a test, whatever the test might be. And there are a number of different tests that can be done. For using antiviral agents, you need to get those into people within 24 to 48 hours of symptom onset. So if a person comes in, they've just recently become sick, and they look like they have, you think they might have influenza as opposed to the common cold, and you're considering giving antiviral agent, you certainly would want to give it with some confirmation, perhaps with a rampant antigen test, even though it's not 100% sensitive or 100% specific. And of course, sensitivity and specificity varies on the type of rapid antigen test you have, but it's certainly quicker than trying to get a viral culture, because if you're going to try a viral culture, you might as well give the person antivirals and not do the test, because what's the point? You won't get the culture back for several days. And the other benefit of doing testing is if you, for some reason, want to prescribe antibiotics, which is inappropriate for most people with respiratory infections, and you're looking to basically find out whether they've got a influenza, and you've discovered through testing that they do, it can prevent the inappropriate use of antibiotics. So that's the other benefit of testing. The other thing is clearly, the test, interpreting the test is dependent on how much influenza is circulating in the community at the time. If you know that there's a lot of influenza based on surveillance in the state and the federal government, you can interpret a test a lot easier by knowing that the predictive value positive is going to be relatively high, as opposed to in the summertime when there's not a lot of circulating influenza. A positive test may not actually indicate that the person's got influenza. So again, the testing, whatever test you do, has to be interpreted in the context of what's happening with influenza in the community. And in a pandemic, at some point in a pandemic, you might not do any testing anymore, because if there's so much virus circulating, a lot of people are sick. If the person comes in and clinically looks like the last person you saw who had confirmed influenza, you might just prescribe antiviral agents for that individual. So let's get to pandemics a little bit more. And I think this is what people are worried about, that the world's ready to explode with this. Although, frankly, watching the news every day, I think it's going to explode for a lot of other reasons besides pandemic influenza, certainly the last few days. Just to be clear here, a pandemic, every year we have essentially, and I can't even say we have an epidemic every year, because every year we expect a certain increase in influenza during the season. So it's just basically seasonal trending of influenza every year. And we don't really have an epidemic of influenza every year, because that's what we expect. So an epidemic is always above what you expect. A pandemic is basically limited to when you've got a novel virus that's basically circulating around the world, and basically infecting a lot of people and making them sick because they're susceptible. And this basically reinforces what I just said about a novel virus. And again, you have a pandemic per se when you have efficient person-to-person spread, although I don't want to be hard and fast on that, because the WHO actually has several pandemic phases. And they're divided into interpandemic, pandemic, alert period, and the pandemic period itself, and then post-pandemic. Although with a pandemic, you can almost call it an interphase part of the pandemic, because you can have cycles. Notice I've highlighted phase 3 in yellow. The reason I've highlighted that, because technically speaking, we are in a phase 3 of a pandemic, but we don't have a pandemic right now. And so how could you be in phase 3 of a pandemic when you don't have a pandemic? Well, if this virus changed and we had a pandemic, then we would look back on this period of time and say we were in phase 3. I mean, that's essentially what it comes down to. And we're in phase 3 because there is human infection with sporadic human-to-human spread, but not sustained and not efficient spread. So we've been in phase 3 now for several years, and let's hope we stay there. This is a calculation of the potential impact on New Jersey. This actually came from a slide prepared by Julie Gerberding at the CDC. It's got some assumptions based on there. We're always asked, how many people are going to get sick? How many people are going to die? Who knows what's going to happen? If we have a 1918 pandemic, we'll have a lot of people who get sick and die. If we have a 1957 or 68 pandemic, it perhaps won't be so bad, at least in terms of deaths. So, you could look at all the numbers, you could change the assumptions, come up with different figures. This is based essentially on 1918 numbers. The bottom line is it wouldn't be very good if it was a 1918 type of pandemic. And the system would be stretched, to say the least, in terms of medical care, but in many other ways as well. The social system would be stretched to a large extent also, especially depending on the mitigation strategies we take to try to decrease the spread of disease, and I'll come back to that in a minute. We're thinking, we had mad cow to some extent, not very much. You know, I'm not going to say much ado about nothing, but it was a lot of you know, what is it, well, there was a lot of noise about basically disease. There was a lot of tempest, but there wasn't a lot of disease, which is a good thing because it's not a great disease to have. And of course, we've got these other things. But bird flu is clearly on everybody's mind. Avian influenza in birds, okay, essentially. We're going to focus on birds because this is a disease of birds, and it is killing a lot of birds around the world, either naturally or through, you know, because of human intervention in terms of culling infected flocks. Type A virus, birds carry this all the time. The virus is natural in wildfowl. Wildfowl rarely get sick with this, or when they do, they may have a small die-off, but it really, they're carriers basically of this virus. And there are all kinds of different avian influenza viruses. And in fact, the USDA with Departments of Environmental Protection are doing extensive surveillance in this country, particularly in the flyways of the country. Avian influenza can survive at low temperatures and low humidity for days to weeks. So clearly, particularly during the fall season and in cooler weather, it can be transmitted amongst flocks. When we talk about avian influenza, we talk about low pathogenic and high pathogenic influenza in birds. Low pathogenic influenza, you know, may cause illness in poultry. And the bottom line is when it occurs, you know, they basically will cull the flocks. We had an outbreak, a very mild outbreak of low pathogenic avian influenza in one of our bird market, our chicken markets here in the state. We've got, I think, 4 chicken markets in the state. They actually have had a very robust surveillance system for many years, even before H5N1 became a concern, because the poultry industry is worried about circulating virus in their flocks. And the Department of Agriculture oversees that program and has a very robust protocol in terms of shutting down the markets, culling the flocks, cleaning the markets before they reopen. High pathogenic avian influenza is a little bit more worrisome. Clearly, it can cause massive outbreaks in the poultry population, domestic poultry, and clearly much more worrisome. And it can be H5, as I mentioned, although what we had in the birds was a low path. Human infection with low path can occur. It's rare. It doesn't really cause very much disease. Here's an example of a few outbreaks of it. When I say a few outbreaks, each of these outbreaks had a few cases and no death. So clearly, low pathogenic avian influenza can cause mild illness in people, but generally doesn't cause much illness. As far as high path avian influenza is concerned, it clearly will infect the poultry, domestic birds. And it also can infect humans, and perhaps more cases. Again, the case fatality rate is really still quite low, although it does happen. And of course, H5N1 is a high path avian influenza, and we first had experience with that in 1997 in Hong Kong when there were 18 cases and 6 deaths. And then, of course, it kind of simmered for a while. We had no cases, and then it basically reared its ugly head again in 2003, and away we went. Now, this slide is meant to represent, you know, to remind me to ask the question of you, how do you think avian influenza is going to come into this country? You know, a lot of people think it's going to come in on birds. You know, it's basically the flyways where they mix in, for example, in Alaska, where it joins Russia, that the birds, you know, the birds from Asia basically mix with the birds from North America there, and then they'll bring it in down the western flyway. That's certainly one way it could come into the country. It could come in all through illegally smuggled birds that are infected. But I would say that, you know, the most likely, if I had to bet on it, the most likely way it would come in would probably be on a human at some point in time. But who knows? This just gives you some indication of confirmed occurrences of H5N1 influenza in poultry and wild birds since 2003, and you can see it's quite extensive. You know, I don't know whether you would call it what's the word? It's not an enzootic, but what's the word for an outbreak in birds? Epizootic. Thank you very much. So, I mean, clearly it's spread around the world, not here in the North or South America, but in other parts of the world it's clearly quite extensive. And there are lots of animals that can be infected, not just humans. And here's an example. Here's a list of all the countries as of April of 2006. that have actually had one or more species of animal that's been infected with avian influenza H5N1. So pretty quite extensive. I talked a little bit already about H5N1 in humans, and right now, I think the next slide, we have had limited, as I mentioned early on, person-to-person spread. That's why we're in phase 3. We've had perhaps, I don't know exactly, but maybe 3 or 4 really pretty well documented cases of person-to-person spread with the H5N1. And the most recent one, there was about 7 or 8 family members that actually had it, where they could not trace down any contact with poultry, which is still really the principal way still of basically the spread of H5N1 to humans. And that's why we're still in phase 3. Give you some idea of the human cases since January 06. And this slide basically is gives you the list of the countries, 10 countries right now that have had human H5N1 cases. Since with the most recent date being 9/19/06, and you can see a little over half the cases have died. So it's quite a severe disease currently, at least the type that's circulating in humans and causing illness in humans. Human illness that's detected. Remember, because there could be some disease detected in people that is mild, although I think the thinking around the world is there's not a lot of mild cases, at least based on some of the epidemiologic work that's been done. So actually the other day I was asked at an influenza advisory committee meeting, what could we tell people how to prevent, disease, how to protect themselves from avian influenza today, aside from, the usual respiratory precautions and hand hygiene and so on. And my comment was, well, don't visit Chinese poultry farms or any East Asian poultry farms where avian influenza has been documented. And I think that that's probably true. Now, I don't think that a lot of us would do such a thing under normal circumstances, but really that's the most likely place where you are to pick up avian influenza today is by visiting places where there are infected birds. Anyway, there are some CDC guidelines about how to protect yourselves and what to do when you return from countries where you may have circulating H5N1. The clinical features to date, basically you got a pretty bad respiratory illness, and in those who've had H5N1, clearly they've been severely ill. We've read about them. Sounds to me like they've mostly had ARDS type picture, just like they did in 1918. And as I say, more than half of them died, partly probably due to ARDS and perhaps partly due to respiratory infection, and perhaps some CNS events as well. This isn't a clinical talk, so I'm going to just skip by that, but they're all very sick. Viral diagnosis, can only really be confirmed through viral culture or RT-PCR. Nasopharyngeal aspirates are probably better than pharyngeal. There have been some fecal samples are positive, and that's important. I just want to mention that you can, depending on the type of strain, viral strain that causes a pandemic is that it can be shed through feces, which then presents a, sort of another mode of transmission of infection as opposed to just respiratory droplets or aerosolization. And I think that people, although traditionally we think of influenza transmission as droplet infection transmission, there's been enough evidence there can be some, under circumstances where you can generate aerosols, that there can be aerosol transmission as well. And that has led to some, finally, I could say, that the CDC has, and NIOSH and OSHA have agreed that under most circumstances for healthcare workers that N95 respirators should be used as opposed to surgical masks. And there was a long debate in those agencies of well, it's droplet infection, you only need surgical masks, you don't need, N95s. OSHA saying you need N95s, NIOSH saying you need N95s. And they finally agreed that N95s is the way to go for healthcare workers who are in the hospital setting taking care of those kinds of patients. In New Jersey, we have issued guidelines based on CDC guidelines of who needs to be tested currently. These are current recommendations. Basically, they have to have a disease that's suspicious for influenza pandemic, and they, recently returned from a country where, in fact, avian influenza has been demonstrated. Or there are some other guidelines as well where they're sick and they have a history of contact with poultry, e.g. visit a poultry farm, household raising poultry, or bird market, or they've had contact with a known case. I don't know that I'm not aware that in New Jersey we've ever tested somebody for H5N1. I don't know whether that's true in other parts of the country. It may be perhaps closer to Asia on the West Coast. We ask patients, clearly taking a history is important. That's always the case. Never, history is everything. If you don't ask the question of whether they traveled or not, you're not going to be able to suspect that it is. And again, reinforcing that avian influenza, pandemic influenza, whether avian or otherwise, if you suspect that it could be a novel strain, you need to report it to the local health department or report it to somebody. I think the guidelines for this is the local health department, but I tell physicians, well, that's the regs, but if you call us or you call the CDC, we'll hear about it. The locals will hear about it. We'll all hear about it at the same time. The key thing to do is to report it, and you don't need confirmation before you report it. We've had a pandemic plan at the state level. We've been working on this since 1999. We're up to the fourth draft of our guidelines, and this latest draft is going to be a complete revamping of the earlier guidelines. It is a work in process. We're going to incorporate the Emergency Health Powers Act that was signed into law about a year ago, actually a year ago, and we're also going to incorporate some of the HHS plans that was released almost a year ago. Let me move on. Our plan only focuses on human health. Agriculture has its own plan for avian influenza surveillance, and the State Office of Homeland Security Preparedness is developing a statewide plan that involves efforts of other departments that would have to respond to a flu pandemic. The state health plan developed by the department is only related to health. And these are the components of the plan: command and control, surveillance, vaccine delivery, antivirals, communications, mental health, and emergency response. And each section is detailed, although again, it's going to completely change. And that should be available probably within a couple of months for review from people. We have a very robust surveillance and epidemiology system in the state. It's about as good as any state as far as I'm concerned. It's got a lot of components to it. It was revamped a little bit this year. Lisa McHugh's now running that program for us in the Department of Health. And how many of you remember getting the revised guidelines from her? Anybody? Peter? Yeah, okay, good. So we're also trying to incorporate the influenza-like illness surveillance system in our CDRSS system, our electronic reportable disease system, as a module, so the hospitals can report influenza-like illness, for example. And there are other surveillance aspects to our system, which I really don't want to get into right now. We talk a little bit about mitigation strategies, and this is what I mean by mitigation strategies. Mitigation is to basically soften the blow, if you will. Vaccine, antivirals, and what we call non-pharmaceutical interventions, which include isolation, quarantine, social distancing, and individual infection control. These are the kinds of issues that you have to consider when you're talking about mitigation strategies. There's both the epidemiologic and the social aspects, and I don't want to go through each one of these individually, but you'll understand this a little better as in the next few slides. What you want to do to control an outbreak depends on the outbreak. It depends on the epidemiologic characteristics of the outbreak in terms of how, incubation period and infection, how it's transmitted. I mentioned a moment ago, if it's transmitted through the fecal route, then that's, in addition to respiratory droplets, it's a different approach you have to take in terms of controlling it. The age distribution, clearly, is who's most susceptible, how do people respond? What is the reproductive rate? In other words, how quickly does the virus infect individuals and make the next individual sick? On the social side is, how do people mix? How do people come together? Are the children getting it and bringing it home? If we impose restrictions on people, will they follow the restrictions? Can we shut down roadways? Can we quarantine people in the home? How do we enforce? All these factors determine what you're going to do to try to control the epidemic, not eliminate it, not prevent it, but dampen it. Well, we have vaccines, and the simple thing about vaccines, there isn't any vaccine, and frankly, when we move from phase 3 or phase 4 or 5, we're not going to have vaccine in the first phase. I think everybody recognizes that. Several manufacturers have contracts with the CDC to prepared prototypes of H5N1. Who knows it's going to be H5N1? How much time do I have left? I'm good. Okay. But, you know, they're preparing H5N1, and what if it's H7N1? Well, you know, H5N1 won't do anything for H7N1, and we've got a long sort of cycle for preparing vaccine, and frankly, I doubt very much that we would have vaccine. If we did, it would be very little vaccine, and then we would have to talk about who gets the vaccine prioritization. I'll come back to that in a minute. As I said, well, I think this repeats just basically what I've said. So there's been some studies that have done on the vaccine. Actually, the early studies that were published by one company showed that it requires a lot of antigen to get an antibody response. So now some more work being done using vaccine that has adjuvants on it to sort of reduce the antigen. Why is this important? Well, if you don't have any vaccine, and then you start to make vaccine, you're not going to have a lot to begin with. And the more antigen it needs to actually get an antibody response, the less individual your doses have for people. So you want to be as close to possible to the current level of antigen that's in the vaccine, which is about 15 micrograms, that actually causes an individual to have an antibody response. And the initial trials show that you needed about 90 antigens to get an antibody response, and even then you didn't get it in everybody. So clearly, and then those are mostly on healthy people to boot. So we've got a long way to go to actually having even H5N1 vaccine. You asked me about the priority groups. These are the potential priority groups as listed in the U.S. Department of Health and Human Services plan that was released a year ago in November. And we don't have any other in the state, other priority listing. I'm asked all the time, what are your priority groups? And I say, right now, if we had something tomorrow, we'd start off with this list, and then we would look at the characteristics of what was happening in terms of the pandemic, and we would adjust the list as necessary. If that doesn't make you comfortable, let me just say what I'm going to tell you next will probably make you more uncomfortable, is the U.S. government doesn't really know that this is the right list. And I know that for a fact because there is now a committee at the CDC that's been meeting and with representation from various organizations to look at the ethics of prioritization and who should be prioritized and how you would prioritize it and what are the ethical elements that would drive how you prioritize people who would get the vaccine. It's not just the epidemiology of the outbreak of the pandemic. It's also, there are ethical issues one has to consider as well. So I don't, we could spend all day talking about this. I don't really want to do that. But these are some of the things, some of the groups that you could consider who would be prioritized for vaccine. Now, this is the same kind of list for antivirals, but the antiviral issue is different, and I'll come to that in a minute. Clearly, this would be a major discussion if we had an outbreak. Yes. The question here will be most likely a federal decision. I would say that for the vaccine, it's likely that the feds are going to control the vaccine, and they're going to set the rules for how the vaccine gets used. And they're going to basically drive it to the states. I doubt it's possible that the states would be given the limited amount of vaccine as it comes off the production line every week, and they might say, well, here are the 5 high priority groups. You could have 5 groups in like a tier 1. And you could say, okay, you could use these in tier 1. Tier 1's your priority, but the state could even prioritize more in tier 1 if they wanted to. I mean, that's the kind of thing that I envision seeing. But frankly, I don't really know because the feds don't really know. I mean, that's the bottom line. You're going to tell me this? Yes.
Don't leave it to the local health.
Oh, no. I would agree. I mean, the federal government doesn't, I would agree with that. If the federal government gives the state flexibility, then the state will determine, because we will possess the vaccine and distribute it out. The real issue is it's not going to be just a decision by, the deputy commissioner or the commissioner. This is going to be a cabinet-level discussion with the outside parties having input. But ultimately, I would bet it would be such a sensitive issue that it would be the governor and the health commissioner side by side who would make the decision, or at least announce what the decision was, and impose that decision on all parties of the state. But everybody will be clamoring for the vaccine. The police will say that they've got to maintain the infrastructure of society. The healthcare workers say we can't take care of patients. I can go on. Everybody, I haven't been, I'm waiting for somebody to put up their hand and saying, but you haven't, yes, thank you. Direct public health care includes public health and healthcare. I use the term public health care because I don't like to separate the two systems. I think it's an artificial separation to say public health and healthcare, so I use the term public health care, and that includes everybody who does health, whether they're in public health or healthcare. Okay? And there, to me, it looks like they're right at the top of the list. You feel better now? Good. And the goals for priority groups are to reduce the health impact, and then of course reduce the social and economic impact. I mean, those are key, and those are very key, because if you've got a society that's not maintained, you've got anarchy potentially. So this is a slide that actually came from 3 years ago when we had the flu shortage, and that's probably likely the situation that we're going to have when we have a pandemic. Antivirals. This is a changing story. The issue has been always a little bit about limited supplies, but every day we don't have a pandemic, we have more supplies. And so the recommendations currently from HHS is, priority groups for treating people, not prophylaxis, because antivirals can be used for prophylaxis. And we're basically talking about the neuraminidase inhibitors, because I don't think the adamantanes are going to work. And as you know, last year there was resistance even for regular influenza with the adamantanes. So, but things are changing. The production capacity for Tamiflu is increased. The production capacity for Relenza is going up. Stockpiles are increasing daily. And pretty soon we're going to have enough antivirals available to have a different strategy for use of antivirals. And actually, because of this increasing stockpile with antivirals, the federal government have had several meetings. I've attended a few of them, where we're talking about a different mitigation strategy, which would include prophylaxis of close contacts, at least early in a pandemic, people who actually have disease. So what would I mean by close contact? First few cases you would have, person sick, all the people who live with that person would get antiviral agents. If the person was in a workplace and they had close contact with people next to them, they would get antiviral agents as well. And I know that there's a lot of modeling that's been done. There are published papers to that effect about using that particular strategy of prophylaxing individuals, close contacts of people who have documented pandemic influenza. So it's a changing picture here, and the prioritization for treatment, I think, is going to disappear in many ways, because it will be actually very hard, I think, to prioritize people for treatment. You've got to diagnose people quickly, and you've got to get it to them very quickly. And as you have more and more supplies, it doesn't become an issue in terms of prioritization. Prioritization more has to do with how you want to mitigate the disease versus treating individuals who you think might respond. And the bottom line is, again, I said this before, you've got to get it into people soon enough, and that's tricky. Think about it. How many people go to the doctor right away when they've got early signs of a cold, or early signs of influenza for that matter? They don't show up for a couple of days or more until they feel like death, and then they show up. Well, it's too late for antivirals. Now, obviously, if we know there's influenza circulating in the community, people are going to be showing up for everything. And then the real trick will be, how do you separate out those who have influenza with those who have the common cold? Because the common cold is not going away when we have a pandemic. It's not going away. Neither is heart attacks, neither is strokes, neither is kidney disease. I mean, all those things are going to keep going. Maybe cosmetic surgery won't keep going. Antiviral resist, I mentioned this before. This is a placeholder. We don't know what the CDC antiviral recommendations are for this coming year. We should hear soon, since the season's going to start next week. Stockpiling, I mentioned. HHS, US HHS, Health and Human Services, has plans to stockpile at the federal level 50 million treatment courses of Tamiflu and some Relenza. 46 million for states. If you prorate it based on New Jersey population, we would get 1.38 million of those treatment courses. Treatment courses. Prophylaxis is different. These are treatment courses. New Jersey, we already have 18,000 treatment courses available. We've already put in our order for purchasing off the federal contract for 900,000 treatment courses of Tamiflu, and we're also planning to order 23,000 treatment courses of Relenza. Relenza is the inhaled neuraminidase inhibitor. And we have plans in place, draft plans for distribution to hospitals and local health departments and fairly qualified health centers or centers for primary health care and first responders as a way of getting that out, to at least our stockpile out and the federal stockpile as well out to the community. And I don't want to get into detail to that except that there is a draft protocol available that has been shared with our Influenza Advisory Committee. Let me move on. We don't recommend personal stockpiles. I'm not going to ask this group how many of you have a personal stockpile. I know a few of you would put your hands up. I know a few of you would put your hands up, and maybe that's okay because many of you are public health care workers, and you think you know when you should take it. You probably would do a rapid antigen test on yourselves before you would take it because you're good clinicians, and you don't want to treat inappropriately. But if the public were to get a hold of it, my response is, well, how do you know if you've got influenza? How would you possibly know you had influenza? So it doesn't make any sense. Same thing I've been asked, well, what about large employers who have medical programs? What should they do? If you've got medical oversight of a program, go out and buy a stockpile. I don't have any problems with that, as long as you've got some rational protocol of how you would give it to your employees. And you need to give it to your employees based on a diagnosis, not just on, I think it's influenza, because you can't really tell necessarily that the person's got influenza or not. So with appropriate control, namely a clinician making the diagnosis, stockpiling's fine, whether it's by an employer or by an individual. But for the general public, I don't advocate it. Other current activities we're doing in the department are educational initiatives. I'm doing one right now today. Basically talking, we have a lot of, these slides that I have today, they're certainly prepared for today. But it's basically, this is a common slideshow that we have in our department. Our staff are going out constantly around the state. We basically changes all the time as information changes. Local health departments, I haven't said much about them, but clearly they are major players here, particularly the links agencies, the major county-based or in two cases, Newark and Patterson city-based health departments. They're also supposed to be developing their own influenza pandemic plans. You guys have a plan? Yes. Yes. Okay, so we're in draft number X mode, and of course you're anxiously waiting to see what our plan looks like so you can modify your plan, right? But really we are requiring, and we're requiring hospitals to develop their plans through, particularly if they're receiving HRSA dollars from the Federal Cooperative Agreement, and virtually every hospital in the state is receiving HRSA dollars. And so we know that hospitals many have already developed their plans. Some have done exercises already to test, tabletop exercises, test their plans. And it's just a constant process. The plan is never finished. Never finished. As things change at the federal level, just like I talked about changing levels of antiviral agents, you're going to basically change how you're going to approach taking care of your employees and your patients. And it's just as important to take care of your employees as it is to take care of your patients, because if you've got no employees, you're not going to take care of your patients. So I've talked about vaccines. I've talked about antiviral agents as a mitigation containment factors, and then there's the non-pharmaceutical interventions. And they can be broken down to social distancing, thinking about as contact interventions, versus infection control, which is transmission interventions. I don't want to go through this in great detail. Social distancing, you're basically trying to create space between people who are sick and people who are healthy. And you may have a variety of strategies you take that you would implement at either the local level or the state level or some level, something that the feds are calling targeted layer containment. And the examples include, I'm going to say quarantine. Isolation is limited to sick people, but you can be sick in a hospital and sick at home, so there's different approaches to isolation. Quarantine is for healthy people who might have been exposed, usually have been exposed. And here are the kinds of things that can be done. Let me just say that, let me go back. Here's what's happening at the federal level. I mentioned to you about modeling for use of antiviral agents. The big issue that is the big discussion that's happening at the federal level is closing schools. And closing schools early in the pandemic. I don't mean closing schools when 50% of the staff, 50% of the children are sick. I mean closing schools when you have a few cases in the community. And as an extension of that, there's a concept that's being used called protective sequestration. What is protective sequestration? Well, it's not good enough maybe to close the schools, which is what the models are saying right now. And the modeling they're doing is based on the 1918 model, although I think they're going to do some modeling on 57 and 68 as well. Okay, so you close the schools, where do the children go? Well, they go on the streets, they go to the mall. If they're old enough, they go to the streets, they go to the mall, they go, they gather somewhere. Now, they're not gathering in the same numbers as they would in a school setting, but they're gathering. And so the next level of a social distancing would be protective sequestration, which is keeping the children at home. Now think about that a second. Remember I talked to you about all the factors you've got to consider? I had the list of epidemiologic factors, and I had the list of social factors, and one of things was the acceptability of the strategy in the population. I don't know how acceptable that would be in the population. Now, if you've got young kids, what are you going to do? Well, if you work, you're probably going to talk to your friends, your neighbors. Well, who's going to be home this week? Or let's rotate, 5 friends. I'll take the kids, I'll take 5 of the kids. You can't have more than 5 because then you become a licensed daycare center. Okay? So 5 kids, that's the definition. If you've got 6 kids, you need to be a licensed daycare center. So 5 kids, you don't need a license. And so that only 5 friends get together, and hopefully they only have, single children. And basically they'll take care of them. Well, of course, that's better than having 30 kids. There's less chance of spreading it. But clearly it's going to impact on the parent if they're, dual income parents both working, or even single parents. What's a single parent going to do is the sole breadwinner for the family. So having closing schools and having protective sequestration as a mitigation strategy has tremendous social impacts. And they haven't figured out, the modeling they've done at the national level has only looked at the benefit of these policies. They haven't built into those policies yet, well, what's the impact on society? How acceptable is society? What is it going to do to the economy, if people aren't coming to work, and so on and so forth. And you can't have a strategy of mitigation without considering the negatives of that. Or the likelihood, what happens if, well, your models in terms of, and let me tell you, those kinds of strategies, when they apply to 1918 stuff, it really does dampen the pandemic. It spreads it out. You have fewer cases, but more importantly, you spread it out. The length of the pandemic. Well, why is that important? Well, the surge capacity on institutions is diminished, or the surge demand on institutions diminished, so you have more capacity. So instead of everybody getting sick at within a 4-week period, you kind of spread it out more, and the shape of the curve is also a lot lower too. So the area under the curve becomes lower if you understand integration, and what happens is you have fewer people who get sick over a longer period of time. So who knows what it's going to be, and it may be the final models that come up are basically going to show, what, the benefits are great for closing schools, and the benefits are great for protective sequestration, but the risks in terms of the economic risks and the social disorder risks are too great for us to do that, and the acceptability of it to the public is very low. And so what are you going to do, shoot people in the street? They're going to shoot children if they find them on the street? I mean, how are you going to enforce something like that? I mean, these are all important questions when you're talking about strategies. In epidemiology, you talk about efficacy and effectiveness, right? You can have a screening test like colonoscopies, remember? That great test, but it wasn't very effective in the community because it wasn't very acceptable to the community, at least in the early days of doing colonoscopy. Things have changed now a little bit. It's more acceptable. But again, efficacy and effectiveness for a strategy are very different. It may be very nice in theory, but if it doesn't work in practice, it's not going to happen. Yeah.
Have you considered just the opposite effect, that when word starts to leak out that there may be a pandemic, that people are going to rush to self-isolate, they're going to
Sure.
hoard food, that they're going to keep all their kids in the house, and you'll have whole communities just rush the other way?
Well, whole communities, like a lot of people in the room, can do that because they make they have a salary and they have money and maybe they have reserves in that. But those communities that are on the margin, those communities that are on the edge, those communities that have very little in the refrigerator, those communities who have nothing in the bank, that's a strategy they can't follow. Those communities who are living hand to mouth, who basically have enough food in the refrigerator because they went shopping that day or the night before, are not going to be able to isolate themselves at home because they got to feed themselves. I mean, at the end of the day, you got to eat. So let me just finish so let me play 3 minutes because I thought there were going to be a lot of practitioners here, but what is it, what is a this is all very interesting. This is a lot of public health kind of stuff here. Some of it is clinical. But of course, in the office, there's a lot that practitioners are going to have to. I was asked yesterday in an interview, what's the role, what's the practitioner? How do they intersect with public health? Well, all we want practitioners to do is sort of follow some of our guidelines, which is basically good infection control. 2 things a practitioner has to do in the office setting, whether it's a clinic setting or whether it's a private practice or even if it's in a hospital setting. Good infection control in the office. Universal respiratory hygiene. Wash your hands. Provide masks to your patients. Separate your patients if you can, when they have respiratory illnesses. And of course, early diagnosis so that we can get people into proper therapy and avoid actually inappropriate use of antibiotics. So institute infection control measures. I've been talking about this for years. Doctors should have practices today in their offices where they're practicing universal respiratory precautions. What I said just a moment ago, separating people, masks. Most are not doing it because they say, who's going to pay for the mask and who's going to pay for it, and I don't have a separate office and so on and so forth. I can assure you that we have a pandemic, they're going to do that. Some of them actually may close their practices, but that's another issue. Infection control, as I just sort of, this is obvious, and some people are doing more of it than others. These are some of our signs. Anyway, let me I think make this my summary slide. And there are other slides in there, as I say, that you can read at your leisure. So non-pharmaceutical interventions or targeted layer containment. We're talking about ill patients who stay at home. And this applies to the non-pandemic situation as well, right? Home quarantine for household contacts, pandemic related. Social distancing, school closures may have some profound impact. I haven't mentioned about workplace continuity of operations. Workplaces are going to have policies in place so that their workers don't come to work. I mean, either they have to give them, vacation time, or they're going to have telecommuting, or they're going to have some policies in the workplace where they keep people separate, and they have good environmental controls in order to reduce the risk of transmission in the workplace. Cancellation of public events is easy to do. The state just can declare that there won't be any concerts or sporting events and so on. Of course, the people who run those events aren't going to be too happy because they will lose money. There will be a cost to dealing with a pandemic that's beyond the medical cost. And then these are the other measures. So this is kind of a summary of the social distancing concept. There are some other slides there, as I mentioned to you, that refers to regular treatment of prophylaxis of influenza with vaccine, and some of the policies we've issued in the last year or so, with links to what those policies are on the website if you didn't receive them a year ago, and I'll leave you to look at that. So I know I've been talking for a while, and there clearly are a lot of questions, so thank you very much.